Hello.
Hi, Yasmin. How are you?
I'm good, thank you. How are you? Can you hear me well?
Oh, can you hear me? I can't hear you.
I can hear you too. That's great. So the connection seems to be fine.
Okay, I think my speaker needs to be allowed. Mm. Mm. Yasmin, give me a second. Yeah, you can hear me, but I cannot hear you. I think my speaker is the issue. Let me fix that. Please try again.
Hello, can you hear me?
Yeah, I can hear you now.
Excellent. That's great. Sounds good.
Yeah.
Yeah. Hello, can you?
Yes.
I think the connection is not great. Um, I think the connection is not right. I'm not sure whether this is
Oh,
on my. I'm not sure whether this is on your end or mine. Can you hear me? Okay.
I can hear you.
That's okay.
I'm in a very
Uh,
obscure place.
say again. Sorry.
Yeah, I'm in the hinterland of the country.
Oh dear, I can't hear you. I'm so sorry. Like I can hear voices, but the connection seems to be broken at certain points.
I'm texting.
Um okay.
That's my son. My son.
Oh bless you.
Hi.
That's okay. No problems at all. That's okay. I think the speaker should join shortly. Um
Can you hear me?
Hi, Omar. I can hear you and see you. Okay, can you hear me?
Yes, I can.
Excellent. Perfect. So we just wanted to make sure that the mic and the speakers are working okay. So it seems fine. Perfect. Thank you very much. I can't hear you now.
Can you see the presentation?
Yeah, I can see the presentation. Yeah, and I can hear you now.
Hear me?
Perfect. Oh, so Omar, I can't hear you. Can we make sure that the mic is okay?
Can you hear me now?
Yeah, perfect. That's okay. Excellent.
Your voice is a little low. Hi, Dr. Omar.
Hello, how are you? Let me just double check. Can you hear this now?
Yeah, I can hear you.
Is it clear?
Yeah, but it's a bit low again. Uh, yeah, sometimes I hear you, and sometimes the voice just go away.
I think every time I speak, you show that it. Would you like me to go out and then go back again in?
Yeah, we can try that.
Is that better?
Yes, yeah, a little bit better. Yeah.
Just let me know at any point you can hear me. Just let me know.
Okay. But can you hear me okay?
I can hear you. Yeah, yeah.
Is my voice clear?
Yeah, your voice is clear.
Uh,
Yeah, I hear you, but I don't hear Dr. Omar.
okay, so it's mm, um Omar, can you please check the settings of your mic?
Yeah, this is what I'm doing now. Um, I'll join back again. Just 1 minute, all right?
Okay. Hi, Omar. I think you're on mute.
Yeah. Can you hear me now?
Yeah, I can hear you now. That's
Yeah,
great.
is that better?
Yeah, yeah. On my end, it's much better. Thank you very much.
Face-to-face teaching, always the technical difficulties. So I think we have 3 people like us to wait for a few minutes, like us to finish.
Yeah, yeah.
Up to you.
Yeah, that's okay. I think we can give it one more minute before we start. Uh, okay. Um, I can start by a quick introduction. But first, everyone, can you hear and see the presentation okay? Yeah, excellent. Perfect. My name is Yasmin Abdullah. I'm RIGAF Egypt National Representative. RIGAF stands for Radiology Interest Group Africa. We have subgroups in Egypt, Sudan, Nigeria, and Ghana. We help students and doctors get access to medical education related to radiology and research. So I'm going to pop the link to our membership that you can get for free in the chat box. And feel free to ask me any questions about RIGAF Egypt after the session. I think I'll hand over the mic now to Dr. Omar. Please introduce yourself.
Right, okay, guys. My name is Omar El Zahar. I'm radiology registrar in West of. And most importantly, I'm very proudly African and Egyptian. So nice to meet you all. I think we don't have a big number, so if you guys want to unmute yourself and ask any questions before we start, I'm more than happy to answer your questions. Does have any kind of input? So the most important thing is that we become as interactive as possible. This teaching was given multiple times. It's a face-to-face teaching. This is how it was designed in the first place. But there's lots of questions, lots of interactions during the presentation. And I would really, really appreciate it if you can guys interact with me and don't just talking. Feel free to make any mistakes. No question is a silly question. Here we teach. And let's start. First of all, starting with the learning objectives. First of all, I would like you, by the end of this presentation, to develop an understanding of fundamental principles of bone fractures, including the mechanisms of injury, clinical presentation, and initial assessment. I would like you to become familiar with the common terminology and terms used to describe upper limb fractures or common upper limb fractures, and developing a basic approach to the interpretation and the presentation of X-rays, demonstrating common patterns, and finally, recognize the common adult upper limb fractures and understand the key principles of their initial management and referral pathways. Well, we don't need the referral pathways that much because this was designed for the um, medical students and foundation doctors here in the United Kingdom. But I'm sure you'll be aware of your referral pathways when then I made some modifications to the presentation so that it is suitable for medical students and freshly graduated doctors. Right, so the first question is arranging the following into severity: fracture, break, and crack. I just want you to match which one of these is fracture, which one of these is broken, and which one is cracked. You guys answer this question. Feel free to unmute yourself and make mistakes. It doesn't really matter.
So I'm going to say fracture, break, and crack.
Okay, so which one of these is fractured?
So 5, 4, 3, 2 are all fractures, and I would say 1 is a crack, maybe.
One is a break. 2. Okay. So as I mentioned, feel free to make mistakes. This is a massive common misconception here in the United Kingdom. If you go to the patient and say, you have a crack in the bone, they would say, at least it's not broken. If you say it is fractured, they would say, at least it is not broken. They feel that a break is much bigger and much more severe than a fracture or a crack. But actually, all of them are the same thing. Fracture equals break equals a crack. This includes both partial or complete breaks in the bone, regardless of the severity of the injury. But what is the definition of a fracture? A fracture in general is a partial or complete break, crack, or disruption in the continuity of a bony tissue, resulting from mechanical forces that exceeds the bone's ability to withstand them. And that's very important when we come to talk about the causes of fractures in general. However, there are multiple terms commonly used to describe the shape, type, and severity of the injury, such as open versus closed fractures, complete versus partial fractures, displaced, non-displaced, avulsion fractures, intra-articular and extra-articular. What does this mean? Like when you hear these terms, what do you guys mean? This is something that we're going to talk about in details, but going to the next question first. What are the causes of fractures? I kind of answered a little bit, but what causes a fracture?
A fall.
Yeah, perfect. Which fall would cause a fracture?
A fall from height, I think.
Yeah, so essentially, it depends on a lot of things. First of all, the strength of the fall, or let's call it the force, and the quality of the bone. Any fracture any fracture is caused by a mechanical force or forces stronger than the bone's ability to withstand them. So the stronger the force and the weaker the bone, the higher the chances or the higher the risk of having a fracture. So we need a force that's stronger than the bone's ability to withstand them. So for example, if you have like example of a force, direct trauma such as falls, accidents, twisting, gunshots can cause fractures, explosions can cause massive fractures. Repetitive movement, for example, someone who's not used to running started running and started making a lot of effort, we call this a stress fracture. Or on the other side, weak bones, and the weak bones gets fractured much easier than stronger bones, such as in metabolic diseases, osteoporosis, parathyroid disorders, bone pathology, such as in bony myths or bony cysts. We usually call them pathological fractures. Can be genetic conditions, such as osteogenesis imperfecta, can be lifestyle problems, such as malnutrition, hypocalcemia, smoking, alcohol, diabetes, or medications like steroids. All of these things are factors that can lead to weaker bones. Okay, so what are the symptoms of a fracture? So when someone comes to the emergency department, you see this patient, and how would you say that that is broken or this is fractured? Can you guys tell me a few symptoms?
So
Maybe,
pain in the area,
Yeah,
not
pain in
being
the
able
area.
to weight bear,
Absolutely, yeah, in lower limb fractures.
swelling.
deformity.
Sorry, say that again.
I said bone deformity, so maybe
Bone
deformity
deformity.
in
Yeah, absolutely. Fantastic. Bruising, all of these are symptoms of a fracture. So pain, swelling, bruising, limb deformity, as you mentioned, inability to move the joint or inability to weight bear if it's a lower limb fracture, symptoms from a complication such as nerve or vascular injury, or shock from a bleeding. If you have a significant bleeding due to the injury, this can lead to hemorrhagic shock, or you have open fractures, which essentially mean that you have a break in the skin as well. And symptoms from the associated injury in general, such as an intracranial bleed or pneumothorax, these things can usually happen with major traumas, such as car accidents or fall from a significant height. And the next question is, how do you examine a patient with a suspected fracture? How would you examine them? You have a patient who is coming with an injury and he is holding his arm, for example. How would you examine this arm? It's telling you that it is painful, he doesn't know what's going on, and you have some symptoms of a fracture. I give you a hint here. Right. So I'll answer this question. So general examination for major traumas, if you have a patient with a high velocity injury or a patient presenting with a significant mechanism of injury, you assess the patient's airway, breathing, circulation, and disability, and that's a completely different teaching. I'm not going to talk about in details today, but it's very important to not neglect the rest of the patient's injury according to what is more fatal than the other. And then the focused examination, which we will be talking about today, very similar to all the examinations. Look, feel, but you don't really listen. It's just looking and feeling, and then you assess the neurovascular bundle. Look, is it open or is it closed, the fracture? If the bone is sticking out of the skin, or is it a closed injury? Is it swollen? Is it bruised? Is it deformed? Is it dislocated? How much can the patient move it? Ask the patient to try to move it themselves before you move it yourself. And then feeling, is there any bony tenderness? Sometimes you can feel crepitus sensation. And then you go to the next, which is the neurovascular assessment. Why do you assess the neurovascular bundle when you have a patient with a fracture? It's one of the major things, one of the most important parts of assessing a patient presenting with an injury or a fracture. You guys know why?
To make sure whether the nerves and blood supply to the bones are affected.
Yeah, exactly. So if you have, like, you guys know that you have the bones and then you have some vessels, you also have some soft tissues, you have some muscles. So sometimes the break or the fracture can lead to severe deformity, and this deformity can lead to injury to one of the vessels or one of the nerves. This is why it's very important to examine the nerves by assessing the patient's distal sensations and assessing the patient's distal movements. If obviously, if there is no pain, you're not going to increase the patient's pain. And you also assess the patient distal pulsations, and sometimes there is no pulsations to be felt, for example, in finger fractures. And in this case, you will assess the patient's capillary refill time. But what are the red flags when you examine a patient? The red flags means that the dangerous symptoms or the dangerous signs that require immediate assessment by a specialist. Even if the patient, even if the patient's fracture can be managed as an outpatient, you still need to refer the patient as soon as possible. One example is open fractures. And again, open fractures is bony fragments or the bony hematoma um, um, breaking the skin and making contact with the free air. Deformity risking nerve damage or neurological deficits, such as reduced or absent sensations and loss of distal motor function. Even if you don't have a nerve injury whatsoever, but you know that this fracture is severe enough to cause nerve compromise or nerve injury in the future, it's still escalated. Vascular injury, and we know the signs of acute limb ischemia, very similar to the signs of a vascular injury. So pale, pulseless limb, perishing cold or cold limb, paresthesia, and the paresis, what we usually call the 4 Ps. These are the signs of vascular injury or particularly arterial injury. Sometimes you can see the vessel actively bleeding, shock from bleeding, tense limb with severe pain. Just a hint about compartment syndrome. There is a condition called the compartment syndrome, and it is one of the dangerous signs. You feel free to write it down and read about it after we finish the teaching. But if you have a patient with an injury and the patient is in significant pain, and you feel that the pain is not getting better with analgesia, and the pain is not consistent with the injury, you need to refer them as soon as possible. And the massive swelling is the last one, because massive swelling or boggy swelling can be a sign of an underlying vascular injury. Okay, how do we assess a fracture on an X-ray? Which I know this is probably one of the most important parts of this teaching. When you have an X-ray in front of you, how would you say whether it's fractured or it's not fractured? Do you have any specific signs? Can you cheat from this one?
If the shadow of the bone is not continuous.
Okay, so which shadow? Is it this shadow or is it that shadow? Or is it this shadow? Which discontinuity? All of these are discontinuity of the bones. Or this shadow.
Yeah.
Yeah. And this is why the most important aspect of assessing a fracture is knowing the anatomy. And by the way, this is the most important thing in radiology in general. Know your anatomy very, very, very well. If you know the normal, you will be able to spot the abnormal. I think someone is raising their hands.
Sorry. Yeah, I think Hannah has raised her hand. Hannah,
Yes.
would you like to say anything?
Yeah, I was just gonna say that maybe it's the cortex. If it's not continuous, then there's a fracture.
Yes, definitely, 100%. Yeah, we'll come to that, and I'll let you answer the question, Dr. Hannah. Um, but the most important part, as I mentioned, is the anatomy. Know your anatomy very well. I'm sure you guys all know about the anatomy. Just wanted to highlight this point. We have for the upper limb, we have the clavicle, we have the scapula, we have the humerus, we have the ulna, we have the radius, and then we have the carpals, metacarpals, and phalanges. And it is also worth knowing the vascular distribution and the nerve distribution and the nerve supply of the limb so that you know which vessels you need to examine. For example, if the patient has a fracture here, you know for a fact that you need to assess these vessels, the radial and the ulnar arteries. If the patient has an injury here, you know that you need to assess all of these nerves, including the axillary nerve. If it is here, you know that you need to assess the radial, ulnar, and the median nerves. So it's very important to know the anatomy for your examination and also for your X-ray assessment. And I'm not gonna go through this. As I mentioned, it's meant to be interactive. So I usually ask doctors to answer the anatomical parts. So I'm not gonna go through it, but you know, this is the normal shoulder X-ray, and you need to know the anatomical parts. And then you have the elbow X-ray, and then you have the hand X-ray. Essentially, if you don't know the normal anatomy, you would think that that's a fracture, for example. You'd think that that's a fracture. You might think that's a fracture because you don't know. Just because you know that this is how the hand looks like and this is how it normally looks like. If you see a lucency here, you'd say, oh, that's a fracture because it is not a joint. I don't think those are two separate bones. It's only one bone. So know your anatomy very well, cannot highlight it enough. And now, Dr. Hannah, would you like to tell us more about the radiological signs of a fracture? And feel free to cheat from this one, actually. And as I mentioned, feel free to make mistakes, guys. Like, it's a safe place, and nobody will judge you. I know that we're mostly all of you are medical students, as far as I understand. So please feel free to make any mistakes. As I mentioned, this teaching was meant for foundation year 1 and foundation year 2, which is equivalent to I think the internship year 1 and internship year 2. So please make mistakes. Feel free. So tell
All
me,
right.
what can you say?
Well, I think there's like a complete fracture because both of the cortices, the cortex of each lateral medial side are not continuous.
Perfect.
And yeah, that's all I can say.
So you're saying there's cortical discontinuity. There is a little bit
Yeah,
of a step.
exactly.
You're saying that there is a lucency here, so the bone is not continuous, right?
Yeah.
And can you see this fragment? But let's point it out here. And this is another bony fragment. So starting with cortical discontinuity plus lucency, and I would say plus or minus lucency really. Like, can you see those smooth lines? Those are the bony cortices, all right? And in the middle, this is called medulla, just the basic anatomy of the bones. So we have cortex and we have medulla. Once you see some discontinuity in the bony cortex, you need to say, well, this might be broken, or most likely that is broken. And also, Dr. Hannah said that's a complete fracture because she can see lucency that's complete from this cortex to the other side or to the other cortex. So cortical discontinuity plus lucency, in my opinion, is probably the most important sign. Bony fragments, as we mentioned, this little tiny bony fragment here, this also is a sign that there is a fracture. And we have a specific type of a fracture called a Vulgent fracture, where you can essentially see only a bony fragment pulled away from where it is supposed to be. Bone overlap or impaction, sometimes you'd see those bones overlapping each other or impacted over each other. Bony deformity, as you can see here, there is an angle here. The bone is not really straight. If you draw a line here and then if you draw another line here, you'd see that the bone is deformed and it's not as straight as it should be. Other evidence of fractures, such as soft tissue swelling and joint effusions, these might indicate fractures beyond them, even if you cannot see them with your eyes. Okay, so this slide is extremely important. Yeah, cortical discontinuity plus lucency, fragments, overlap or impaction, bone deformity, or other evidence such as significant swelling or joint effusion. Right. So now I know my anatomy and I successfully spotted a fracture. How can I describe a fracture on an X-ray? Before we jump into that, we need to understand the common terminology used in describing a bony injury or in describing a fracture. Because you can see the deformity, you can see the abnormality, but you don't really know what to say, which is a big problem radiology juniors in general face. You can see the deformity because you know the anatomy, you know this is abnormal, but you don't know how to talk about it, how to describe it. This is why we're going to talk about the common terminology we usually use, starting with open versus closed fractures. So an open fracture is an osseous disruption in which a break in the skin and underlying soft tissue communicates directly with the fracture and its hematoma. What does this mean? It means basically that the bone is sticking out of the skin, or there is a break in the skin, and from this break, you can actually reach the bone without reaching any layer in between. Okay, so this injury, okay, this is a real X-ray for that patient, and this injury, this is an open fracture because there is an injury here, and this injury is communicating with the bone. This is another example of an open fracture. This I think this was reduced later on, but this is essentially how it looks like. So this is an open fracture, but it was reduced later on. And again, open fracture means that the bone is sticking out of the skin, or you have an injury and you can see the bone, or you can kind of reach the bone without reaching any barriers in between. And this is the definition of an open fracture. Again, that's an open fracture. You can even see it from X-rays. You can clearly here see the ulna sticking out of the bone. You can also see here the distal part of the humerus is sticking out of the bone, and it's communicating with the, there is no skin, there is no soft tissue. You guys probably all know that that's a soft tissue, and this is bone. Right? Okay. And the closed fractures. This is a closed fracture because there is no break in the skin, and the skin is intact, or the wound is not communicating with the fracture or its hematoma. So again, open fracture. Sorry. Open fracture and closed fracture. Complete fracture. So Dr. Hannah talked about complete fractures, and the meaning of complete fractures is fracture that extend all the way across the bone. So it disrupts both cortices. We have lots of examples. From these examples is transverse fractures, and from its name, it means that it is transverse. We have the linear fractures, and from its name, again, it is linear, very descriptive. It is quite uncommon to have a linear fracture, but it exists. Oblique fracture, probably one of the most common types you would see, and oblique, from its name again, it is oblique. This is oblique, but oblique and displaced, and we're going to talk about the displacement in a minute. And you have a spiral fracture, and the spiral fractures usually result from twisting injuries, and it is usually spiral, as you can see here. Green stick fractures. Green stick fractures are essentially fractures where one of the cortices is disrupted, but the other cortex appear completely intact. So one, like it's more common in pediatric fractures, and from its name, it's called the green stick, because if you have a green stick and you try to bend it, it's gonna bend from one side first before it breaks from the other side. And this is where the name came from. Comminuted fractures mean that the bone is broken into multiple pieces. And these are essentially the commonest, or maybe all the kind of fracture types, plus a couple of more types that I tell you about later on, maybe. Okay, so again, incomplete or partial fractures, we talked about the complete ones. Again, the green stick fracture, and we also have something called bowing. We have something called bony fissures, and we have something called torus fractures. So the fissures are usually unicortical fractures, as you can see here from the image. The bowing, again, it is bowed, so you will see the deformity, but you will not be able to see with your own eyes the fracture line. But if you get this bone and you put it under the microscope, you will actually see some micro fractures on this side. Again, green stick fractures, where the bone bends from one side and then it breaks one of the cortices and it stays the same from the other side. And this usually happens because pediatric bones are usually more flexible and easier to bend. And again, the last one is the buccal fracture or the torus fracture, also very common in pediatrics. one side of the bone bends, there is a compression on the other side. As you can see here, this is the compression. And then fracture displacement. We have two types. We have non-displaced fractures and we have displaced fractures. As you can see here, the non-displaced, the bones are well aligned together without significant gap or cortical irregularity, as you can see on this bone. Yes, there is a break there. You will be able to see the lucency, but the bone is not displaced. It is well aligned and it is still in place. And then we have the displaced fracture where both bones are pulled from their normal alignment. You'll see this bone or this part of the bone on a place and this part of the bone in another place. Guys, is that clear so far? Or is that I cannot see you, I'm just seeing the presentation, but hopefully it is clear. Dr.
Yeah,
Yasmin,
it is clear.
fine, okay. And then the fracture displacement, again, we have something called angulation. And angulation, as you can see here, there is an angle here, and this is usually measured in degrees. And as a general rule, when we say angulated, or when we say for example, it is displaced, we are talking about the distal part in relation to the proximal part. So when, for example, we say anterior angulation, this means that the distal part is anterior and the proximal part is at its place. If we say, for example, dorsal angulation, we know that this is dorsal. So this means that the distal part of the bone or the distal fragment of the bone is dorsally angulated. If we say volar, this means that the peripheral part of the bone is volary angulated. And this is a general rule in describing the fracture displacement. Translation is usually measured in milliliters, as you can see here, and usually describes the distal part again in relation to the proximal part. Again, displaced, this one is angulated, this one is shortened, and this one is rotated. So you kind of like having a general idea about the terminology that is usually used in X-ray reports, or even in orthopedics ward rounds, or even the A&E. If you're planning to work in the A&E, or if you did any shifts in the A&E, you will hear these terms usually used when describing a fracture. And then again, like just a real life view, that's a displaced fracture. As you can see here, the bony fragments are not well aligned together. It seems displaced. And also to tell you about the displacement, this is dorsally angulated and dorsally displaced, okay? Because this is the dorsal part and this is the volar part. So we are describing the distal part of the bone, and this one is non-displaced. You can see the cortical irregularity, you can see the lucent line, but there is no displacement, there is no angulation, everything seems to be in place. And then other types of displacement or other types of or other descriptions is compression, and usually compression is quite common in spinal fractures and or vertebral fractures, and you have the impacted fractures, which is also like very commonly seen in practice, especially with the neck of femur fractures. So compression and impaction. And then the other type is a avulsion fracture. And a avulsion fracture usually happens when a ligament or a strong tendon pulls part of the bone off. So this is not supposed to be here. This is being pulled from here because you have a tendon that you cannot see on the X-ray that has pulled the bony part away. It's also quite common in pediatrics, but still can happen in adults as well. So again, a avulsion fracture, very, very important. If you see like a bony part that doesn't look where it belongs, basically suspect an avulsion fracture. And then extra-articular versus intra-articular. From its name, extra-articular means that it is not involving the joint, and intra-articular means that it is involving the joint. And here we've also written down non-displaced because you can see the fracture line, but it is not displaced from where it should be. Again, that's a proper X-ray example. So this one is extra-articular. You can see the fracture line here, but here that's intra-articular because you can see the fracture line clearly here extending to the joint. So we call this intra-articular. This one is extra-articular. Right, that's an example approach to bony X-rays description. And it is really up to you how you would like to use the description, or how you'd like to describe the bone, as long as you are structured and as long as you mention everything. But this is what I personally use. So I usually start with the X-ray views and site. For example, I would say this is an AP X-ray of the wrist. And then I would say the patient details, for example, for Mrs. Mary. And then I would say the type of the fracture, complete, incomplete, or Salter-Harris. Don't worry about Salter-Harris. That's a pediatric type fracture. We're not going to talk about it today. And then I speak about the fracture site. Where is the fracture exactly? So you talked about the type of fracture, and then the fracture site. Is it proximal humerus? For example, is it distal radius? Is it above the condyle, supracondylar fracture? Depends on the fracture site. And then I talk about the displacement. Is it non-displaced? Is it angulated, translated, rotated, or impacted? And then I talk about anything else. Is there any joint involvement, intra-articular extension or not? Is there any underlying pathology? If there is any callus formation happens when the bone is healing. Is there any fractures? So this is kind of my structured approach to describing X-rays, and I used this when I did orthopedics in the past, and I probably still use it at the moment in radiology as well. So if someone would like to explain what they can see, and as I mentioned, feel free to make any mistakes you'd like to make. It's not an issue at all, and I don't expect you to get everything right. How would you describe this X-ray? And I gave you like some stuff here to cheat from. Can someone describe this X-ray?
Can I?
Yeah, absolutely, yeah.
Okay, so X-ray view is anterolateral, I think.
Yeah, AP and lateral. Perfect.
Okay, and the site is the wrist joint.
Yeah.
Patient details is a 35-year-old male named Mr. Walker.
Perfect.
Type of fracture, honestly, I don't remember, but I think it's like the one that looks like a bamboo, the buckling. I'm not sure if it's right or not.
Yeah, so I'm going to help you. Let's do it together, all right? So
Yeah.
that is a complete fracture, and this part of the bone is the distal radius.
Yeah.
All right? Okay, so what is the type of the fracture? How does it look like? Does it look oblique?
Transverse.
Yes, perfect. Well done. All right. Transverse fracture of
the ulna. No, sorry, the radius.
Yes, perfect. All right, that's the distal radius. Yeah.
And displacement, I'm not sure, honestly.
No, that's fine. Is it? Do you think it is slightly displaced?
Yeah, it is slightly displayed, but I forgot. Like, do we mention it like the distal part first, or do we say it's a proximal displacement?
So we describe the distal part in relation to the proximal part. So we see how it is displaced. Is there an angle here?
Yeah.
Yeah. Would you say that this is dorsally angulated or volarly angulated?
Polary?
It's dorsally angulated. So this is
Dorsally?
the dorsal
Okay.
part, and this is the volar part. Perfect. Yes. Well done. So dorsally angulated, and it is mildly displaced. Right. Anything else? I personally cannot see anything else, but well done. Perfect. You did it beautifully. Nice. And yeah, again, the same thing, X-ray, AP, and lateral view of the right wrist for Mr. Walker, showing minimally displaced distal radius transverse fracture with dorsal angulation. And I cannot see any other fractures, so I'm not gonna comment on anything else. All right, so well done. You did most of it. Would someone like to volunteer to describe this X-ray? And I'll help you, I promise. So sorry, I cannot see names. So if you guys are chatting on the, if you're writing down, if you're typing, I cannot see it properly. Right. Okay, so let's go straight to the answers. So that's X-ray, AP, and lateral view of the left wrist for 35, or let's say 65 years old Mrs. Smith. This is showing displaced fracture, displaced distal radius transverse fracture. You can see it is clearly transverse, and you can see it is clearly displaced. With evidence of intra-articular extension, the picture might be a little bit difficult to interpret. Sorry, so this is the intra-articular extension here, right? And there is an evidence of intra-articular extension, and it is volary angulated fracture. And as I mentioned, always remember that we describe the distal part in relation to the proximal part. And let's look for anything else. Can we see anything else? Yes, we can see a little bit, a tiny little bony fragment here. And this looks like it's coming from the ulna. And because we know the anatomy very well, we know that this is coming from the ulnar styloid. So we can say there is an associated ulnar styloid avulsion fracture. I hope that's clear so far. You guys have any questions before we go straight to the common upper limb fractures and talk about specific types of fractures? No questions? If you're asking on the group chat, sorry, say that again.
No, thank you.
Okay.
That's really clear.
Thank you. All right, so common upper limb fractures, we have clavicle fractures, proximal humerus fractures, humerus shaft fractures, supracondylar fractures, and these are usually or most commonly pediatric specific. Elbow fractures such as the olecranon and radial head, radius and ulnar shaft fractures, and then distal radius fractures, scaphoid fractures, and metacarpal and phalangeal fractures. These are the commonest upper limb fractures. We're just going to talk about some of them, not all of them, but I hope the principles or the main principles on interpreting X-rays and on interpreting whether there's a fracture or not is clear. Again, I cannot highlight enough how important the anatomy is. Know the normal anatomy. If you're confused, like maybe open your phone and like check Google Images for the normal X-ray of the humerus, for example, and you'll be able to identify the differences between both of them. And then after knowing your anatomy, you know how to interpret X-rays in general. Right, so this part is quite interactive, so please try to interact with me. And again, feel free to make any mistakes you want, it doesn't really matter. So that's a 28-year-old male presenting with severe pain and swelling as shown down in the picture. All right, and he had a fall earlier onto the right shoulder from a standing height and heard a crack near the right side of his neck after falling. What is the most likely injury? So if you look at this and you see this swelling, what would you say? Which bone is fractured? Which bone is usually
The clavicle. The clavicle.
The clavicle.
the clavicle? Perfect, well done. Okay, how would you assess this patient?
Start with an ATE assessment first to make sure he's stable.
Perfect, well done. And then assessing the fracture itself. Yeah, do you remember the look and feel?
You look, you feel. Yeah.
Perfect, all right.
Yeah,
And then
exactly.
would you assess anything else away from the fracture? Would you assess the nerves?
The nerves.
Yeah.
Yeah, the
And
nerves and
the pulsations. Perfect, well done. All right. And you would definitely do an X-ray. So the X-rays were done and the X-rays showed this. What do you think of this? Is it normal anatomy or is it broken?
broken. It's broken.
And what is broken exactly?
Broken.
The clavicle.
The clavicle.
Clavicle.
The right clavicle.
Perfect. And you said the right clavicle is broken because you know the right clavicle is usually nice and crisp and it is usually straight. You know that there is no toe bones here. The clavicle should usually be straight. How would you manage this fracture? I will tell you how to manage this fracture because it is quite difficult. But again, clavicle fractures, you need to remember your normal anatomy. This is the normal clavicle and this is how it looks like. And this is a broken clavicle, as you can see here. And it's very important to remember that the brachial plexus lies very, very close to the clavicle. And you also have the subclavian artery and subclavian veins. So beware of these vessels and these nerves. They might be injured with a clavicle fracture, especially if it is significantly displaced. All right. So with clavicle fractures, the mechanism of injury usually a fall onto the lateral aspect of the affected shoulder or direct impact or direct push. And 75 to 80% of these are in the middle 1/3 of the clavicle, because this is usually the weakest part. If you see, most of the examples I have mentioned are usually in the middle third of the clavicle, as you can see here. The presentation is usually popping or cracking sound after a fall, obviously tenderness, swelling, crepitus, deformity over the clavicle, plus or minus skin tinting. Examination focus points, again, assessing subclavian vessels and the brachial plexus. What complications should we look for? Again, neurovascular compromise, and sometimes like long-term complications can be malunion, non-union, and the post-traumatic arthritis due to the sternoclavicular joint or the acromioclavicular joint. Quickly, just talking about this terminology, you don't need to know them now, but malunion means a healing in a bad place or in a bad position. Non-union means that the bones would not heal at all. Post-traumatic arthritis, usually the joints very close to the fracture can develop arthritis, and you have the sternoclavicular joint and the acromioclavicular joint. Both joints can develop arthritis if the fracture didn't heal well. Right, basic focused management. Most injuries are conservatively managed in a pulley sling with follow-up x-rays if isolated, closed and neurovascularly intact with no skin tinting or risk of compromise. Basically, as a summary, most of them are managed in this and they get discharged home, unless you have red flags that we talked about, and the red flags are open fractures. If you have any open fracture anywhere, even in the finger, just refer to orthopedics and let them deal with it. Obvious skin tinting. Sometimes the skin can be tinted more than that. This means that the skin is about to be penetrated, and neuro or vascular compromise. And we already know what this means, and we know what is at risk of getting injured. More images of clavicle fractures. Again, here is, as you see, like most of the images available are middle third of the clavicle. And this is an example of how they are managed surgically. Just in case you see an x-ray that having plates and screws on the clavicle, know that this is probably a previous clavicle fracture that was treated with a plate and screws, or we call this intramedullary tens nail. Proximal humerus fractures. Again, anatomy, I'm not going to go in details into this with you because I'm sure you already know your anatomy. And with proximal humerus fractures, again, you need to know the vessels that pass through, and you need to know the nerves that are closely related to the injury so that you can assess them properly. Then going to the mechanism of injury, usually low energy falls in elderly people with osteoporotic bone, because we said that if the bone is weak, you don't really need a strong force to break this bone. Or high energy trauma in young, healthy individuals with strong bones. So it's quite a strong bone to be fractured, really. So it needs a high force of trauma, but this is not necessary in elderly people. Even a minor fall can lead to significant injury. Representation, usually shoulder pain, swelling, the relevant arm is bruised, as you can see here properly, and usually held to the chest with the contralateral hand. So you usually see the patient presenting in this position. And the complications, shoulder dislocation is not uncommon with proximal humerus fractures. Axillary nerve injury is the most common nerve injury. Axillary artery can also be injured. Shoulder stiffness later on, and avascular necrosis. And avascular necrosis essentially means that you have cut the blood supply from one part of the bones, and this part of the bone will die with time. This is what we mean by avascular necrosis. So no vascular supply, the bone will necrose and will die. And again, as I mentioned, the axillary nerve is very closely related, so it's very important to assess it. And just a tip, to assess the axillary nerve, you need to check the sensations above this area. We call it the regimental or the military badge area. Assess the sensations here, because sometimes the patient cannot abduct their shoulder properly, so you might not be able to get any sort of movements. And here you have the axillary artery, and the axillary artery is very, very closely related to the humeral head, so there is also high risk of injury to the axillary artery. But axillary nerve is the main one, like very, very important to assess it with proximal humerus fractures. How do we treat them? Conservative management for most of them in a sling or collar and cuff for 2 to 3 weeks, and operative management, closed reduction or open reduction and internal fixation, intramedullary nail fixation, hemiarthroplasty, which means it's changing half of the joint, and the reverse shoulder arthroplasty, this is where we change the whole joint. I know that's a bit complicated, but it might be useful to know these things in case you see an X-ray and you see a specific metal work and you say, oh, what is that? Why are they doing that? At least you will understand why do they have these kind of metal works. So we know the anatomy. So that is the surgical neck that is fractured here. This is the greater trochanter, and as you can see, the greater trochanter is fractured here, and this actually is dislocated. So the greater trochanter is fractured, and the joint is dislocated. As you can see, the humeral head is not in the socket, it's not in the glenoid fossa. You can see it clearly outside of the glenoid cavity. So again, this is the greater trochanteric fracture, and you have this is the metalwork that is used. This is the plate and the screws, and this is called the reverse shoulder arthroplasty. And by the way, it is called reverse because they put the humeral head here, okay, or they put the head here and then they put the cavity here. This is why we call it reverse shoulder arthroplasty. Yeah, by the way, like this is the greater tubercle. I know that probably I said tuberosity. This is greater tubercle, or it's not the trochanter. It's called the tubercle or tuberosity. And then humerus shaft fractures. Humerus shaft fractures, again, know your anatomy quite well and know the nerves that are closely related to the humerus shaft. Now we have finished with the proximal humerus fractures, and we have the axillary nerve, and we know that the axillary nerve is at risk of injury here, but here with the humeral shaft fractures, the radial nerve is the one at most risk of injury. This is a spiral fracture that we talked about before, and as I mentioned, it is usually due to rotational mechanism of injury. And all of these are similarly examples of humerus shaft fractures. Okay, so the proximal humerus fractures are going to be here or above this line, and then from here down, these are all humerus shaft fractures. How do you get them, or what is the mechanism of injury? Direct trauma to the arm. This is the most common, or fallen out stretched hand. What is the presentation? We have arm pain, swelling, bruising, all of the symptoms that we already know, and you can sometimes get symptoms from the radial nerve injury. And you guys probably remember the signs of radial nerve injury. You have, depending on the site of the injury, you'll have elbow drop, you'll have wrist drop, and you'll have fingers dropped as well. Humerus shaft fracture management, most of the times, or 90% of the times, it is fractured, it is treated conservatively, whether with a U-slab, humeral brace, or a hanging cast, and I will show you those as well in a minute, or operative, again, open reduction and internal fixation. When you see that, assume it is plate and screws, or intramedullary nail fixation, and intramedullary from its name, it goes into the medulla of the bone to keep the bones nicely aligned together. This is the U-slab, and you can like get from the image, they do counter traction and the traction, pull the arm down, and then put a slab here, or put some cast here, and then they put a bandage around it. This is the U-slab. This is how it looks like to make the fracture nicely aligned together. This is the hanging cast, and this is the brace, and this is my favorite. The brace is very nice, and it keeps the fracture nicely in place. So the again, the conservative management, this is how the U-slab looks like on an X-ray. So if you see an X-ray with a fracture and a slab that looks like that, you can confidently now say, oh, that's a U-slab. It looks like a U. And this patient has a humerus shaft fracture. So I know that this patient was treated conservatively in a U-slab. Right, and again, this is how it is managed operatively. This is open reduction and internal fixation, essentially plate and screws. You can see the big plate and you can see lots of the screws here. And this is the intramedullary nail fixation, a nail going through the whole of the humerus. That's case 2. Would someone like to volunteer and go through case 2? I need someone who's brave to go through case 2. Again, don't worry about making mistakes. I'll be helping you.
Before we start, can I just ask a question, please?
Absolutely, yeah.
So in the slide before this one, usual in the internal fixations, the screws are like penetrating the other side of the bone. Is that like normal, or does it cause any complications like for the soft tissue or nerves, or I don't know?
Yeah, that's an excellent observation, a very, very good question. And this is something we saw from the radiological perspective, actually. Yeah, so usually, because I did orthopedics, so I know exactly how these are done. So usually they would measure what is the end of the other side or what is the end of the other cortex. And they would usually put a screw that is a little bit like very close to the cortex, but not penetrating the cortex. If it penetrates the cortex a little bit, it might not cause any problems. But sometimes we get complications. This can be bleeding. This can even be up to bowel perforation and like viscous perforation from people who used nails that are longer than needed. So that's a very good question. Yeah, so ideally it should not go through the other cortex or can go a little bit, but not so much. I would say that this one, I wouldn't be massively worried about this one. This one is all right.
Okay, thank you.
But ideally it should be like that. But yeah, perfect. Very good question. Right. Would someone like to take this case? All right, so I'll go through it quickly. That's a 20-year-old male presenting to the A&E after falling off his motorbike onto the right forearm. This was followed by inability to move the forearm, along with the swelling and the bruising. As you can see here, there is a swelling and there is bruising. And after stabilizing the patient, x-rays were done that showed the injury on the right side. What is fractured here? Can someone at least tell me what is broken?
The
The
ulnar
ulnar?
and the both
Yeah.
are
Both are not.
radius.
Perfect. All right. So when you examine this patient, is there anything unusual that you noticed on this patient? That's a hint. That's a big hint.
Is it like an open wound?
Sorry?
An open wound?
Perfect. All right. And what does this tell you about this fracture? That's an open wound, and actually it is communicating with the fracture. What does this tell you about the fracture? What kind of fracture is it?
An open fracture.
Perfect. Well done. So that's an open fracture. As long as the fracture or its hematoma is communicating with the wound that's open on the skin, that is an open fracture. And this highlights the importance of examining the patient properly. So how would you assess this patient? How would you examine this patient? I think you are all now experts on assessing patients presenting with injuries and the fractures. How would you assess this patient?
As always, start with an ATE assessment, make sure the patient is stable,
Perfect.
and then move to the injury location, look,
Yeah.
see, and feel.
Yeah. Perfect. So you can see deformity clear here. You can see swelling, you can see bruising. If you try to ask the patient to move it, it will be extremely difficult to move it because it's very painful, but it is quite important to assess the patient's pulsations. And I would personally assess the pulsations, the radial pulsations and the ulnar pulsations here. And also, even if the patient has some difficulty on moving the limb, they can at least show you that the radial nerve is working fine. They can also show you the rest of the nerve, even with a slight movement. And if the patient cannot move it at all, you can at least test the sensations to make sure that the nerves are working and the patient doesn't have a major nerve injury. Okay. What is the primary management? I would talk about the primary management because it's quite complex. So for open fractures specifically, they have a specific protocol here in the UK at least. So first of all, according to the BOST guidelines, we remove any gross foreign body. We take medical photography from the injury. We cover the wound with saline-soaked gauze and an occlusive film, and we give the tetanus vaccine. Extremely, extremely important, whether here in the UK or in Egypt or any country. Please make sure that you give the patient tetanus vaccine. And prophylactic intravenous antibiotics. Bony infections can be extremely, extremely painful to treat, and the patient can take like ages. Sometimes it is chronic. Osteomyelitis can remain for years. Please make sure that you give the patient prophylactic early intravenous antibiotics. And as usual, realign and splint the fractured limb and directly refer to the orthopedics team, to the local orthopedics team in your hospital. Or if you have a different policy, make sure that a specialist has seen the patient on that day. And this, in a nutshell, is the management of open fractures in general. But now, going back to the radius and ulnar shaft fractures, which is the type of fracture we have just seen. In general, radius and ulnar shaft fractures, they are also known as adult both bone forearm fractures. The mechanism of injury is usually either direct blow to the forearm or axial loading on the forearm through the hand. So the patient has fallen into an outstretched hand or even a hand in a volar position. And it is very common with motor vehicle accidents. Presentation, as you have seen, usually gross deformity, involving pain, swelling, bruising, and loss of forearm function. The patient cannot rotate the forearm. The patient cannot move the forearm properly. Clinical assessment, again, careful examination for any open wounds because they are more common with long bone fractures than short bone fractures. Neurovascular assessment, including examining the radial, ulnar, and median nerves, is very, very, very important. And these are some subtypes of both bone fractures. I don't know if this is part of your curriculum, but it's very, very important to remember these names here in the UK. We have the Montague fracture and we have the Galeazzi fracture. You don't have to remember them, but your consultant might test you on the type of fracture because that's very common. That's very well known between medical students here. Montague fractures and the Galeazzi fractures. So the Montague fractures is usually the ulna is fractured and the radial head is dislocated out of the joint. And with Galeazzi fracture, so the distal radius or the radius shaft is fractured and the distal radioulnar joint is dislocated, as you can see clearly here. Radius/ulnar shaft fractures, again, these are examples of the both bone. That's, I would say do you guys know, like from this image, would you be able to classify what kind of fracture is this? So this is the ulna is fractured, and this is the radial head is dislocated. You remember the name? Does anybody remember the name? So this is Montague fracture. And again, that's another one, Montague fracture. And this is Galeazzi fracture because the radius shaft is fractured and the distal radioulnar joint is dislocated. And this is just radius. This is just radius fracture, radius shaft fracture. There is no dislocation and the ulna seems intact here. But how do we manage them? Conservative management. That is very rare in patients who are not surgical candidates or if the fracture is non-displaced, which is extremely rare. These fractures are usually most of the times displaced. I probably have not seen it ever in my life when it's not displaced, unless it is a pediatric patient, a pediatric kind of patient. And operative management, again, forget about the external fixator. That's a bit too complicated. But open reduction and internal fixation. Sometimes we do bone grafting if there is significant bony loss, and intramedullary nails can also be used. Right. So the rest fractures, this is probably the last topic, and rest fractures are extremely, extremely important. And again, before we get into the abnormality, it's very important to remember how the normal X-ray looks like, and this is how usually it looks like. There is no anatomical variant. So remember the normal X-ray so that you can spot the abnormal. So this radius fracture, why is it very important? Because it is the most common orthopedic injury in adults and generally results from fall on outstretched hand in the rest in dorsiflexion. It's extremely, extremely common because probably falling on outstretched hand is one of the commonest kind of injuries anyone. I think everyone, even here during this meeting, had a fall at some point and they landed onto an outstretched hand trying to prevent further damage or head injury. Associated injuries, distal radioulnar joint can be injured as well, the radial or the ulnar styloid, and most of the times it is just soft tissue injury. Again, clinical assessment, open versus closed, and please do not forget about the neurovascular assessment. What are the subtypes of distal radius fractures? We have the Colles fracture, which is extra-articular with dorsal angulation. We have the Smith fracture, which is also extra-articular, but with volar angulation. And please remember, this is dorsal angulation, and this is volar angulation. So if this bone is fractured, with dorsal angulation, this is called Colles fracture. If it is fractured with volar angulation, this is called the Smith fracture. And the bottom fracture, when there is an intra-articular involvement, these are special types of fractures, are quite rare, but they still exist. Again, that's an image that explains the different types of fracture. So again, the Colles fracture, it's extra-articular, and there is dorsal angulation, okay? And the Smith fracture, it is also extra-articular, and there is volar angulation of the fracture. And again, the Bartons and the dorsal Barton and the volar Barton, or the reverse Barton, both of them are intra-articular type of fractures. Again, a closer image, Smith fracture and Colles fracture. Is that normal or is that abnormal? Can someone volunteer to tell me? Does that look normal to you? Or is it abnormal?
It's normal. It's abnormal.
It is abnormal. Perfect. Yes, it is abnormal. So what's abnormal about it? Can you see a break? Can you see a fracture?
Yeah, the bone looks like it's compressed.
I wouldn't say it is compressed, but I would say it is a bit angulated. So if you look at this fracture, can you spot where the cortical irregularity is? Yeah, if you look at the cortex, if you follow the cortex here, okay, so there is a step here, and there's a little bit of lucency. Can you see that? And if you follow this, they are actually not very well aligned, okay? And if you follow this as well, okay, so something doesn't look right here, right? Okay, and if we talk about the displacement, is it displaced or is it undisplaced? Is it only the line that you can see, or do you feel that it is going somewhere else? Do you feel that it is slightly angulated, for example?
Yes, someone Yumi mentioned in the chat box that it's dorsal angulation.
Perfect, well done. Yes, that's dorsal angulation. So this is the distal radius fracture with dorsal angulation, and this is consistent with Colles fracture. Again, looking at the Colles fracture, this is how it looks like. And this is exactly how this injury looks like. That's this Colles fracture with dorsal angulation. It is very subtle, but well done on spotting that. And again, this one, is that normal or is that abnormal? It's very harsh, I have to say. Like this one is hard, but let's look at this one. This one would be easier.
Abnormal?
Yes, that's abnormal. Perfect. So there is a fracture, right?
Yes.
Yeah. Okay. So is there any angulation in this fracture? Is there any displacement? Yeah, it is angulated, isn't it? And would you say that's volarly angulated, or would you say that's dorsally angulated?
Volar angulation.
Volar angulation.
Volar.
Perfect. Well done. Well done. Okay. So this radius fractures quickly, the primary management, manipulation plus casting, very, very important. Usually this is the main part of the fracture. Especially, well, these are the local guidelines on my previous hospital, but it essentially tells you which ones to refer, which ones not to refer. But most important management step is manipulation and the casting. And this is how it looks like in the cast. So they essentially put it back in place and then they put a cast over it, or open reduction and internal fixation. And I said usually with the ORIF, like assume that they mean by that plate and screws, and this is also another way of managing it. So if you look at the X-ray and you see a plate and screws at this side, you'd say, oh, maybe this patient, well, probably had a fracture before, and this is actually fresh. So you can still see the cortical irregularity and the little bit of lucent line here. It hasn't 100% healed yet. So this is the end, but other type of fractures to look at in general, supracondylar pediatric fractures, which is essentially the fracture on the supracondylar region here, and there's many types of it. And this is how the X-ray usually looks like. You can see the break here, and you can also see this is massively, massively displaced. You can see the elbow here, and this is the these are the condyles, and this is the humerus shaft, and it is massively displaced. So this essentially should be here. Shoulder dislocation, also extremely important. It is not technically a fracture, but it is a very, very common injury, and it is worth looking at images and reading about it. Olecranon fracture, another type of elbow fracture. This is called the olecranon process, and this is where the triceps usually attaches, and it is a kind of a vulgent fracture where the triceps pulls this part of the bone and takes it away. And scaphoid fractures extremely, extremely common and are very important. So you know how the scaphoid looks like, and you can clearly here see the cortical irregularity and the lucent line that we talked about. So that's a scaphoid fracture. And it's very important to remember not to miss this fracture because it has like retrograde blood flow. So if you cut it from here, you might cut the blood flow, and this can lead to avascular necrosis. And again, avascular necrosis means death of the bone because there is no vascular supply. These are the suggested topics to read about. If you want to take a screenshot, if you want to take an image, feel free to do so. And these are the references. Thank you very much for listening. Do you guys have any questions? Does anybody have any question? Sorry.
I can see the claps,
Thank you
hearts
very
and
much.
hearts.
Thank you. I really appreciate it. Guys, if you have any questions, please feel free to ask on the REGAF, even on the REGAF group.
Can
You
we
can
get
just,
a slide, please?
I don't know
Yeah.
how to send them, but yeah, I'll speak with Dr. Yasmin, and we'll try to send you the slide over.
Yeah, no worries. If you join the REGAF Egypt WhatsApp group, I can share the slides there with you.
Yeah, and I really,
So-
really appreciate feedback. I really hope that the teaching
Okay, let me
was.
join.
Sorry. I hope the teaching was to your level. I tried my best to make it as simple as possible because, again, as I mentioned, this teaching was meant to be for foundation doctors or internship doctors, essentially. But I tried to modify as much as possible. If there is anything that was not clear today or something that you want to ask about, feel free to ask about on the REGAF group. And yeah, it was lovely talking to the people who were interactive today. And hopefully things go well with you.
Thank you so much, Dr. Omar. The
much.
session is really fruitful.
Thank you.
It was really beneficial.
Thank you very much.
So everyone, if you check the chat box, you'll find the link to join REGAF Egypt WhatsApp group. You'll find also a link to fill the evaluation form. So please fill it out
Yes.
to get the certificate to deliver to your email. If you have any questions, just let me know. Okay. Thank you very much, everyone. Thank you. Take care.
Thank you so much.
Thank you. Have a lovely evening. Bye.